Everyone. The This is the first lecture of this year, that is aesthetic considerations in fixed prosthodontics, and these are the various learning outcomes of this presentation. Components of structural aesthetics, which is also known as macro aesthetics, various components in smile designing. We'll also be talking about shade selection and the procedure required to do a proper shade selection. So coming to the background, smile is a person's ability to express a range of emotions with the structured movement of the teeth, the lips, and the orofacial musculature. The search for beauty can be traced back to the earliest of civilizations, that is in 800 BC and in 900 BC. At that time, various animal horns and teeth were used, ivory were used to replace missing teeth in the human dentition. Now coming first to the components of structural aesthetics, which is also known as macro aesthetics. This deals with the overall structure of the face and its relation to the smile. To appreciate the macro aesthetic component of any smile, the visual macro aesthetic distance should be more than 5 feet. That is, when we examine the patient's face for the structural aesthetic, we should stand at minimum at a distance of 5 feet from the patient to observe all the facial features such as his forehead, their eyes, their interpupillary line, their chin, their philtrum, the nose, the midline, and the symmetry of the face. All these things have to be observed at a distance of 5 feet. Now, structural aesthetics mainly involves the study of the facial composition, that is analyzing, evaluating, and treatment planning for facial aesthetics. And it is a multidisciplinary approach that provides various specialties such as prosthodontics, orthodontics, orthognathic surgeries if needed, and periodontal therapy to improve the white and pink aesthetics. Now, in smile designing, the following four microaesthetic guidelines are considered fundamental, that is analysis of the facial midline, the analysis of the facial thirds, the interpupillary line and its relationship to the occlusal plane, and the rickets E plane. Now here in facial aesthetics, that is in structural aesthetics, we usually evaluate all these components that I just talked about. Moving on. Now these facial aesthetics can be divided into horizontal and vertical dimensions. In the horizontal dimension, in the vertical dimensions, or the we have few components, and in the horizontal dimension we have a few other components. The horizontal and vertical dimensions are as follows, that is, the width of the face should be the width of the 5 eyes, that you can see in the picture over here on the right hand side. The width of the face here should be the width as if it is the width of 5 eyes kept in a straight line on the face of the patient. That is considered to be the ideal facial aesthetics. And the distance between the eyebrow and the chin should be equal to the width of the face. That is, the distance from the eyebrow to the chin of the patient is the same as the bizygomatic width of the face of the patient. That is a 1:1 ratio between these two components. Okay. Now coming to other vertical components, like I said before, the face is divided into facial thirds, that is 3/3, that is from the hairline, that is from the forehead to the eyebrow, from the eyebrow to the tip of the nose, and from the tip of the nose to the chin. These are the 3/3 that ideally should be in the ratio of 1:1:1. Okay. So the full face can also be divided into two parts, that is when the eye being the midline, that is the interpupillary line, the nose, and then the chin. The lower part of the face is from the base of the nose to the chin, and the upper lip forms the one third of it, and the lower lip and the chin form the 2/3 of it. So the lower third is divided again into three parts, that is from the nose to the upper lip is 1/3, and from the upper lip to the chin is 2/3 of the measurement. So these are all measurements that are taken at the beginning of the facial analysis. Now coming to the shape of the face. The shape of the face itself has been known to influence the teeth shape, the teeth selection, the selection of the mold for the teeth in complete dentures as well. And here it is also no exception. Usually, according to house classification, we have 4 different face forms, that is the square shaped face form, the tapering face form, the ovoid face form, and a square tapering face form. Similarly, the teeth mold or the teeth design can also be selected based on primarily the shape of the face of the patient. Next is the profile or silhouette of the patient, which are again according to House classification in complete denture prosthodontics. I hope you can recall this from the lectures of the past year. So here we have a straight, convex and the concave facial profiles. That is the convex and concave are known as a retrognathic and prognathic facial profiles. These factors play an important role in determining the tooth shape, the tooth size and the lateral profile. In short, the tooth morphology is dependent on these facial analysis. Lastly, I also mentioned the Ricketts E-plane. Ricketts E-plane is a plane that is connects 3 points, that is the tip of the nose, the lips and the chin. So this E-plane, or is also known as the aesthetic E-plane, is not a new thing. It is there since the early 1950s and the 1960s, when on orthodontist Dr. Rickett observed that for an ideal aesthetic profile, the Ricketts E-plane, the lower lip should be 2 mm from this plane, that is inside this plane, and the upper lip should be approximately 4 mm inside this plane to be considered an ideal aesthetic profile. Okay, so this is useful when you are doing full mouth mock-ups. Full mouth temporaries are given to the patient to evaluate whether the depending on the support of the lip from the teeth, whether we need to reduce the thickness of the teeth or we need to enhance the thickness of the teeth in order for the lip to be placed more anterior or more posterior to the Ricketts E-plane. Coming to the components of the smile design itself, the smile design components are the components of the oral cavity, or also they are also known as oral components, which have two major components. These are the tooth components itself and the soft tissue components, that is the soft tissue surrounding the teeth. So in tooth components, briefly I'll just mention them over here. We'll discuss about them in detail. We have the dental midline itself, the length of the central incisors, the dimension, that is the ratio proportion of the length to width ratio of the anterior teeth in the aesthetic zone, the zenith points, the inclination of the anterior teeth, the interdental contact position, the incisal embrasures, the SPA concept, as sex, personality and age, which was previously given by Fresh and Fisher in 1952. Then we have the symmetry and balance of the dentition itself. When we look at the soft tissue components, we have mainly the gingival health, the gingival level and the harmony of the gingival level, the interdental embrasures, that is the cervical embrasures, and the smile line. So coming to the dental midline. Now dental midline, we all are aware, we also use the same concept in the complete denture construction and fabrication itself. So dental midline is the first reference midline for the fabrication of any restoration for the smile designing for oral rehabilitation. It should be perpendicular to the incisal plane and should be parallel to the midline of the face itself. So dental midline in most cases is parallel to the midline of the face, but in certain cases minor discrepancies may be detected. Like in this picture over here, we can see the midline is shifted about 2 to 3 mm to the left of the face of the patient. So minor discrepancies of up to 2 mm are acceptable, and they can or cannot be adjusted depending on the patient's preferences and the operator preference. But any discrepancy of more than 2 mm has to be adjusted, keeping in mind during the planning of the treatment for any smile design or oral rehabilitation procedures. However, if a midline is canted, then this is unacceptable. That canted midline usually indicates a canted occlusal plane, and that needs to be corrected. Various anatomical landmarks that help us in detection of the dental midline are the nose, the philtrum of the upper lip, the ala of the nose, and the midline of the lower teeth as well. But as I mentioned, the midline should be parallel to the long axis of the face itself. Minor discrepancy of 2 mm are acceptable. It should be perpendicular to the incisal plane. And the midline should drop straight from the papilla, that is the interdental papilla between the central incisor. It should drop straight through the interdental papilla. Okay, so this is how a midline should look. We should not rely on the mandibular midline, because in many cases the mandibular midline does not coincide with the maxillary midline. So when we are considering or recording the dental midline, we should always record it in a proximity or to the reference of the facial midline, that is the midline of the forehead, midline of the nose, the philtrum and the chin, rather than focusing on the midline from the lower teeth. Okay. Next component, tooth component, is the incisal length. Now, maxillocentral incisors are the most important teeth during any smile design or rehabilitative procedure because they are the reference or the landmark teeth. And from these teeth, we will be setting up the proportion for the lateral incisors, for the canine, for the smile line, for the incisal visibility. These are the benchmark or the primary markers for establishing the smile. So the length of the maxillary incisors is very important. The various parameters that help us determining the incisal length are the degree of the tooth visibility when the patient's lips are at rest. We can also gauge the incisal length in case of patient with severe attrition, severe tooth surface loss, where we do not know where exactly to establish the incisal length or the incisal plane. We can rely on the phonetics, that is the use of fricative sounds like F and V is very helpful here. We can take input from the patient regarding whether he or she considers the incisal length to be too long or too short. Okay, so here we can see usually at rest in younger individuals 3 to 4 of the incisal display is visible. So we have to determine the length of the incisors keeping that in mind. As the individual's age, the incisal visibility reduces, so then the incisal length will be shorter as compared to the younger individual. This is mainly because of the attrition of the teeth, because of the lack of tonicity of the musculature, drooping of the nasolabial fold, and with age there will be more exposure of the lower anterior teeth than of the upper anterior teeth. Okay. Next, as I said, phonetics is also very helpful in determining the incisal position of the central incisors as well as the lateral incisors. We can use the M sound to determine the tooth display at rest. We can use the E sound or the to determine the tooth visibility or the incisal visibility during smiling. We can use the fricative sounds F and V and S for determining the exact length and labiolingual position of the incisal edge. Okay. Next, we have the two dimensions itself. Now, as I mentioned previously, central incisor are the most dominant teeth that dictate the smile of the patient. So, usually central incisors should have a width to length ratio of 4:5, and an average a central incisor should always be at least a minimum of 10 millimeter long, and it can be more depending on the length of the patient's face and the degree of the tooth display that is desired. We have various guidelines for determining the tooth dimension of the anterior teeth in the frontal plane. You might have heard of this many times. We have something called as a golden proportion, the recurrent aesthetic dental proportion, M proportion, and a choose aesthetic gain given by Dr. So golden proportion is very common. Like a lot of people, a lot of textbooks, articles mention about golden proportion. For a few who are still not familiar with golden proportion, they were based on Fibonacci's numerical series in which each number is a sum of the preceding two numbers. So usually they would be in a series of like 1, 1, 2, 3, 5, 8, 13 and so on. So in nature we find that golden proportion is found in most things that have an ideal aesthetic appeal, whether it be a sunflower, a butterfly or anything, or a seashell, anything. So but we have to use this golden proportion with caution because many a times strictly adhering to golden proportion limits creativity and may lead to cosmetic failures. So they should be used as a guide. All these proportions should be used more as a guideline, and the operator should rely on inputs from the patient as well as his own clinical experience. Okay, so we can see golden proportion is usually a measure of the proportion of the width of the teeth in the frontal plane. That is, in the frontal plane we can see the whole width of the central incisors, the whole width of the lateral incisors, and only we can see the mesial half of the canine. So usually they are in a ratio of 1.6:1:0.6. Okay, so this is ideally the golden proportion, and the maxillary central incisor has a width to height ratio of 4 is to 5. That is, if the length of the central incisor is 10 mm, the width will be around 8 mm. Sometimes it is possible to get your smile design or the rehabilitation procedures, restorative procedures closely within the limits of the smile design. Like here we can see these proportions are 1.7, 1.06 and 0.68, which are pretty much very close to the golden proportion of 1.6 to 1 is to 6, but it is not always possible. This depends to a lot of extent on the shape of the arch, whether you have a U-shaped arch, you have a ovoid arch, you have a tapering arch. Usually when you have arches like tapering arches like in Kennedy's class 2 division 1 and 2, in such cases strictly adhering to golden proportion will lead to cosmetic failures. Okay, now when we consider maxillary incisor, as I said, the width is usually 80% of the height, which is a 4 is to 5 height to width ratio of the central incisors, and the central incisors are usually 2 to 3 mm more wider than the lateral incisors. The canines are usually 1 to 1.5 mm more wider than the central incisors. Okay, and the canine and central incisors are about 1 to 1.5 mm longer than the central incisors. This is the same principle that we also follow during the teeth setting for complete dentures using the glass plate. If you remember, the lateral incisors are usually set 1 to 1.5 mm above the glass plate. So here we can see again, if central incisors have a height of 10 mm, usually the width is 75 to 80% or 4 is to 5 height width to height ratio for the central incisor. Okay, so and the other teeth will just follow the central incisor. Next up is the buccal corridor. Buccal corridor refers to the dark space between, or the negative space when the patient smiles, between the corner of the mouth, that are commissures of the mouth, and the buccal surfaces of the maxillary teeth. This is known as the buccal corridor, and the buccal corridor is influenced by the width of the smile of the patient, the width of the maxillary arch, the tonicity of the facial musculature, the position of the labial surfaces of the upper premolars, and the prominence of the canines. Okay, so we can see here the patient has a very wide smile, she has moderately full lips, and here the arch appears to be more of a tapering type of arch. So here we have a large negative space in the buccal corridor. This to a greater extent depends upon the shape of the maxillary arch. So ideally if a patient has a U-shaped arch, then the buccal corridor can be obliterated like over here. But if the patient has a tapering arch form like a Kennedy's class 2, not Kennedy's, Angle's class 2 ridge relationship, in such cases there will be more dark space or more negative space, or a more prominent buccal corridor, which cannot be held. We cannot edit that. Okay, so next is the zenith point. Zenith point is the most prominent or the most apical position of the gingiva on the labial surfaces of the anterior teeth, or for that matter on any teeth. Usually the zenith points are slightly distal to the long axis of the teeth. So you can see over here, these are the long axis of the central incisor, the lateral incisor, and the canines. Usually the lateral incisor and the canines have a mesially tipped long axis, and the zenith point will almost coincide with the long axis of the teeth, whereas since central incisors are very straight, the zenith points are usually distal to the long axis of the central incisor. Here you can see they're about 1 mm. So this will help in determining the contour or the emergence of the crowns or the veneers that we are going to plan for this patient, or if they, or when we are doing gingivectomy or gingivoplasty in patients with a gummy smile. In those cases also, the determination of the zenith point will help in placing or in this plastic periodontal procedures. Okay, in how we need to alter the periodontium, the gingiva, so as to have an ideal aesthetic profile. Okay, so these are very important. Next is, as I said, zenith points are connected with each other. So we also have to see the symmetry of the zenith, that is on the right and left side, they should coincide and match with each other. And this line ensures that the zenith points on both the sides are symmetrical, so we need to match it, and if any discrepancy we can adjust it using gingivectomy or gingivoplasty procedures. This line also helps us determine the required proportion of the teeth. Like I told, maxillary incisors should have a width of uh, 80% of the length of the central incisors. So in such cases, when the patient has very short teeth, or in such cases we can alter this zenith point, so that we can have ideally restoration with ideal proportions. Next is the tooth inclination, which I just briefly spoke about. So usually central incisors have a straight inclination, lateral and canine have a mesially tipped inclination as opposed to the central incisors. So here we can see just the same. So we have to take notice of this. These are also not only important in prosthetic procedures but also important in orthodontic procedures. So the guide for the labial inclination of the teeth are as follows. The maxillary central incisors are vertical. The maxillary antral incisors are slightly tucked in at the cervical. This is a labial lingual inclination I am talking about now, not a mesodiscal inclination. So central incisors are usually straight. Lateral incisors, cervical portion is slightly tucked in. The canines, the cervical portion is more tucked out, more prominent. That is the opposite of what it is with the lateral incisors. This is how ideally it should be. Okay. Now coming to the interdental contact area. Okay, that is in terms of fixed partial dentures or FPDs, it is known as the connector area. So usually the connector area will be the largest in between the central incisors, and then it will reduce. So there will be, ideally we should have a 4 mm contact between the central incisors. Between the central and lateral we have a 3 mm contact area. Between lateral and canine we have a 2 mm contact area, and between canine and premolar we have 1.5 mm. This to a large extent is determined by the zenith, the inclination of the teeth, as well as the depth of the incisal embrasures. These are the incisal embrasures which are below the contact area, and these are coronal to the contact area, and the depth of these incisal embrasures will ultimately determine the position of the contact area. So usually they follow a 50-40-30 rule, that is 50% contact between central lateral 40%, between lateral canine 30%. The increasing of the interdental contact area helps to create the illusion of the longer teeth, helps eliminate any kind of dark triangles that may appear between the teeth. Okay, so next is the interproximal contact point. So interproximal contact point is the most incisal aspect of the interdental contact area. So where the teeth first make contact with each other is known as the interproximal contact point, and it will be more coronally positioned between the central incisors, and as we go towards the canine, the position shifts more apically, as seen in the picture over here. Now next let us talk about the incisal embrasures. So depending on the tooth anatomy, tooth morphology, the interdental embrasures increase in depth as we go from the midline more distally. So between central incisors we have only 20% depth of the incisal embrasures. Then between the central and lateral we have 30% depth of the incisal embrasures. Between lateral and canine, because canine has a more sharp apex, pointy apex, so here the incisal embrasure has a 40 to 50% depth, and between the canine and premolar also it is between 50%. Okay, so these are very important in developing the tooth shape and the tooth morphology. So we need to have understanding of the incisal embrasures, the interproximal contact position, interdental contact area, the golden proportion. These all fall under something known as mini aesthetics. So these have to be very carefully managed for proper aesthetic results. Okay, so here's in a nutshell we can see the symmetry of the zenith points, the length to width ratio according to golden proportion, the incisal embrasure depths, so all these, and the interproximal contact positions, all these can be seen over here. Okay. Now coming to the sex, age and personality and its influence on the smile designing. Now we know that with age the teeth will appear more worn out. In younger individual, teeth are more sharp with pointy apex, they are not worn, they have well defined incisal embrasures, they have high value. Okay, Whereas with age, the value or the darkness of the teeth increases, the teeth become more worn out, more flat, the incisal embrasure depth is also very less. So we have to keep all of this in mind when evaluating the patient for smile design. Okay. With respect to sex, in female the tooth shape or tooth morphology is more rounded and more soft and delicate, whereas in male this is more robust. With respect to personality, personality is defined more by the maxillary canine. So if a patient has aggressive, hostile personality, if you want, we can give a sharp, pointy teeth for a patient with rugged look. For patient in which we want to create the illusion of a passive and soft smile, we have to create a canine with a more rounded, soft cusp. So I'm sure you all have seen this movie Renfield, in which Nicolas Cage is the vampire. So basically, the canines will determine the personality of the individual. Now coming to the soft tissue components. Remember, we have two components, tooth components and soft tissue components when we are talking about smile designing. So we just now covered all the tooth components. Now we are going to cover the soft tissue components. So basically, gingival health is very important when we are giving direct bonded restorations or indirect bonded restoration, whether it be crowns, veneers. Okay, the health of the gingival tissues is very paramount in order to avoid the dark interdental dark triangles or the exposure of the margins of the restoration or the failures of the restoration. So usually we all know that a healthy gingiva is more firm, has a stippled appearance, is pink in color, does not bleed on probing. Okay, it should be located 3 above the alveolar crest of the bone, and interdentally it should be 5 above the crestal bone. That is when we have ideal papillae. So here we can see next is the gingival level. Establishing the correct gingival level for individual tooth is key in creating a harmonious smile. We can give a nice smile prosthetically, but if we want the smile to be harmonious, that is to be having a symmetrical smile on the left and right side, we need to consider periodontal plastic procedures in order to create that harmony. Usually central incisors and lateral incisors will have an elliptical or a round shaped gingival profile, whereas the canines and premolars will have a more more elliptical or oval shaped gingival emergence profile. So this can be created by gingivectomy. Okay, and also the gingival margins of lateral incisors are 0.5 to 2 below that of the central incisors. So when the central incisors gingival level is this, then the lateral incisor usually should be about half to 2 below or coronal to the gingival level of the canine and the central incisor. Okay, so next coming to the interdental embrasures. So interdental embrasure, also known as the cervical embrasure, is present above the contact area. So this is the contact area, interdental contact area. Below this is the incisal embrasures. Above this is the cervical embrasures or the interdental embrasure. So for to have ideal embrasure, the distance from the crest of the alveolar bone to the tip of the papilla should be 5 or less. If it is more than 5 that is if it is 6 or 7 then the chances of developing an interdental dark triangle at the time of giving the restoration or after giving the restoration increases. Okay, and nobody wants interdental dark or black triangles. Okay, they look clearly aesthetic. Like over here. So here we have a large distance from the interdental crestal bone to the crest or tip of the interdental papilla, which will ultimately result in a black triangle. Here we can close this by increasing the interdental contact area, by increasing the depth of the incisal embrasures, but in some cases it will create an overhang in this area, which should be avoided. Okay, otherwise it will result in swollen and inflamed gingival tissues. Next, coming to the smile line. Now smile line refers to the imaginary line along the incisal edges of the teeth, and it should not be confused with the lip line. Smile line and the lip line are different. Smile line as an imaginary line drawn across the incisal edge of the teeth when we view the patient in a frontal plane. Okay, so this ideally should be parallel to the upper border of the lower lip or to the lower lip line. It should be parallel to this in harmony with the lower lip line. If it is this type of smile line is known as a consonant smile line. The other type of smile line is known as a non-consonant smile line when the patient has severe atresia and tooth surface loss or flattening of the anterior teeth, creating a flattened incisal profile or a reverse smile line. So in that this type of cases they are known as non-consonant smile line. So here we have an ideal smile line. Okay, so smile line also depending on the visibility can be low smile line. Normally in the smile line the junction between the tooth and the gingiva should not be visible, or just the teeth and the interdental crest of the interdental papilla are visible. When the patient has a gummy or a high smile line, usually more than 3 to 4 mm of the gingival tissue also will be visible. So in such cases, the aesthetic or the placement of the margins, the zenith points, the gingival level becomes very important. Okay. So next, let us move on to the shade selection. We covered all the components of the structural aesthetics, components of the smile designing, and come to the shade selection. Now, color of an object is determined by the light that enters the human eye. We all know that humans, we can only detect visible light which is in the visible spectrum of 400 to 700 nanometers. Any wavelength of the light which is above or below it, like the X-rays, gamma rays, infrared, are not visible to our eyes. Okay, so what the color we see is the color which is reflected from the object that we are seeing it. Okay, so we the color are usually there are three primary colors, that is the green, red and blue, and when these three are mixed together we get other sets of four colors like yellow, cyan, white and magenta, which are known as secondary colors. Okay, now these colors are not very important to us. I'm just briefly talking about this color mixing, that is additive color mixing or subtractive color mixing is usually very important in the paint industry or the textile industry, not for us. So we won't spend too much time on this, but when we're talking about shade selection or the procedure for shade selection, we should know that the shade of the teeth comes from two types of color system. That is, one is the Munson color system, which is a more visually descriptive color system, and second is the CIE-LAB color system, which is a more quantitative color system. So the Munsell color system was the first color system that was developed by Albert Henry Munsell, and this describes the colors in a three-dimensional space possessing hue, value and chroma. So this was the Munsell's color space, in which you can see this vertical axis defines the lightness and darkness of a color, that is the brightness of an object, and around this the circle is known as the hue. Hue is mainly the primary or the secondary color, that is red, green, yellow. These are the primary colors. Okay, and along with it the secondary colors, that is cyan, magenta, white, blue, these are all secondary colors. Okay, so and we also have chroma. Somewhere in between them is the chroma defines the intensity of a color, whether the color is light or dark. Now we have, for example, light red color or dark red color, we have sky blue color or dark blue color. So chroma is the intensity of the color, like when you drop a drop of ink or a dye in a clear water, so where the drop touches the water first, it will be the most intense dark, so this is known as the highly chromatic color, whereas as it goes down and dissolves in the water, the color will become more lighter. This will be having known as the low chromatic area. So chroma is just the intensity, whether something is more, has a more strong deep color or a more lighter color, and value is the brightness of an object. Okay, so next is the CIE lab color system, which I said is a more quantitative type of color system, and this is the color system that we use in dentistry, because in this color system each color is given a number, a numerical value, so we can quantify the color, so this is a more precise form of shade selection, and that is why it is employed in dentistry for shade selection. So CIE lab is the shortened acronym for the color system given by the Commission d'Eclairage in France. Okay, and LAB is not a laboratory, it is, they are acronyms for L stands for the value, A and B stands for the different color coordinate. There are two color coordinates in this, which I'll talk just now. So this is the CIE lab color space. As I mentioned, L is the lightness and darkness. That is, something is very light, it will be white. Something is very dark, it will be black. And A and B are the two color coordinates, which if determined by a negative and a positive pole. So when something is said to be having a negative A value, it will be more green, and if it is having a more positive A value, it will be more red. Similarly, the B coordinate also has negative and positive at its two end. So in this color space, if something is having a negative value, it will be more blue, and if it is having a more positive value, it will be more yellow. Okay, so this is what we employ in the dentistry, and the difference between each shade is determined by something known as delta E. So delta E is the average of the, or the sum of the LA and B values. So color perception. Okay, now spectrophotometer studies show that the teeth, human teeth, have a hue, that is a color range between 6YR to 9.3Y. So as I mentioned, the CIA lab quantifies the colors. So here YR means the human teeth have a yellow reddish pigmentation, 6YR to 9.3 yellowish. So human teeth have a hue of yellowish red or yellow. The other colors do not matter to us over here. Okay, and a chroma range of 0 to 6. Okay, so the color perception involves three people, that is us, the operator, the patient, and the type of light source under which we are observing the patient. So we have basically three type of light sources, that is the chair light, which is an incandescent light or an incandescent bulb. We have the daylight or the sunlight, which is known as overcast sky, which is the ideal daylight and in the noon. And then we have the fluorescent light, that is the tube lights or the lights in the ceiling. Okay, so all of these have different wavelengths, and when we observe the teeth under these lights, we will get a different perception of shade, uh, obviously because the light under which we observe the patient plays a very significant role. Okay, the most ideal way to observe a patient is using color corrected lights. So so these are the various lights and their temperature in kelvins. That is, incandescent light or the fluorescent light usually have around 3000 Kelvin temperature, whereas the color corrected light and LED lights have something between 4200 to 2700, and the overcast sky has a temperature of 6500 Kelvin. Okay, so these are very technical, we don't need to worry about that. We just need to ensure or remember that the most accurate shade selection can be done at a in a light which has a temperature close to 5500 Kelvin, which is available with the color corrected light. So these are some examples of color corrected light. Dimitron Kerr, which has a color temperature of 6500 Kelvin. We have Bright Light Pro by Ad Dental, which has three modes. So it has a color corrected light which has a temperature of 5500 Kelvin, which is the ideal temperature to observe the teeth. We can even use different modes in it to observe the teeth in incandescent, in overcast sky, and in fluorescence. Okay, so next, coming to the shade guide itself, this is the Vita Lumen shade guide. We all are familiar with it, we all use them clinically, and I think this is the most universally used shade guide in the entire world. So Vita Classic or the Vita Lumen vacuum shade guide is made from porcelain. Actually, these shade guides are made actually from porcelain in a vacuum furnace. That is why it's called as a Vita Lumen vacuum shade guide. Whereas we have another shade guide by Ivoclar Vivodent A to D shade guide, which is also very popular. These are made from high impact reinforced polymethyl methacrylate. So these are not ceramic shade guide, these are resin or PMMA shade guide. Okay, but nevertheless they are also accurate, and they are in this the shades are arranged based mainly on the chroma, that is the intensity of the color. So you can see this is the lightest shade, this is the darkest shade over here. So here the mainly the shade is arranged in according to chroma. in the Vita shade guide, the shades are arranged according to the hue, that is the color. That is, we have different shade tabs, the A, B, C and D. In A we have an extra shade tab of A 3.5. In D we do not have D1. Okay, and the most accurate shade guide is the Vita 3D Master. When we are talking about analog shade guides, this is the most accurate shade guide because it has 29 shade tabs, and here the shades are arranged based on the value. Okay, here in the Vita Classic the shades are based on the hue, that is the type of the color, that is yellowish or reddish color, whereas here the shade, you can see here the shade, the teeth are arranged based on the value. So the first one here as the bleaching shade guides, you can see over here. In the Vita Classic also nowadays you get a separate bleaching shade guide for checking or evaluating the shade of the bleach teeth, and they are arranged in different tabs like 0, 1, 2, 3, 4. Okay, and each has 3 rows with the exception of the first and the last one. So these 4 rows are arranged according to the chroma. So in the middle we have the a balance shade guide. On the left we have a more lighter or the yellowish shade guide. On the right we have a more reddish shade tab. So these are arranged according to value, and in value also they are arranged according to the chroma. So this is the most accurate shade guide, Vita 3D Master. It takes some use getting used to it, but is very it's not very difficult to use this shade guide. Another one is the ChromaScope by also by Ivoclar Vivadent. Okay, again here the shades are arranged based on uh, the the chroma or the intensity of the color. You can see over here this is more yellowish, this is more brownish, this is more grayish, this is more blackish. So here the shade tabs are arranged according to the chroma or the intensity of the color. That's why it's known as a ChromaScope. Okay. Another type of digital shade selection is done using a spectrophotometer. We also have colorimeter, which is used to measure the absorbed light from a liquid, which is the first colorimeter made by Shofu Dental, Japan. And this is a digital spectrophotometer made by Vita, and it is a very super easy shade guide and does not require any prior knowledge of shade selection. Very easy to use, very accurate shade determination, and it is based on the CIE lab shade guide. You can even get the exact CIE LAB values, that is the lightness value, the reddish greenish value, the bluish yellowish value. You can get everything from this, and this will give you shades both based on the Vita 3D Master and the Vita Classic shade guide. So you can see here it's written as 1.5 M2. So that means here the shade is has a value of 1.5. M is the shade has been selected from the middle tab, and 2 is the second row from the middle tab. Okay, this is the 3D Master shade tab, and it also gives you the Vita Classic shade tab. That is, here it shows that it is similar to the A1 shade guide, and this color at the bottom will determine how close it is to the original shade of the shade tab. Okay, so this is very easy to use. It usually has a calibration tile over every time before you use it. You have to calibrate the device, and it barely takes a couple of seconds to determine the shade. Okay, now coming to the procedure for shade selection. Okay, so shade selection should always be done in an airy area or in an open area where you have lot of sunlight or incandescent light coming in. You have a lot of ambient light coming in. Patient should be upright. The operator should be standing at a distance of at least 2 feet from the patient. And shade selection usually should be done at a diagnostic appointment or at the before the tooth preparation. Okay, because when we keep looking at the teeth, our eyes become fatigued. So we should do say shade selection as the first thing during the appointment. And if the patient has a lot of stains, calculus, or thorough prophylaxis should be done prior to the selection of the shade. And if the patient should be told not to wear any gaudy lipstick or any shiny jewelry because this will create a distraction during selection of the shade by the operator. And as mentioned, the shade selection should be done ideally in the using the color corrected light like the Dimetron and the Right Light Pro. And if not possible, it should be done in multiple sources because of metamerism. So we should do shade selection under the chair light, we should do shade selection under the LED light, we should do shade selection by taking the patient closer to the window when during the overcast sky to under the sunlight. Okay, so this is ideally when we are doing shade matching for tooth which has surrounding adjacent natural teeth. But of course, if you are doing smile designing or an oral rehabilitation, we can choose the shade, or the patient can choose any shade, because we are going to anyway prep all the teeth and all the teeth in the smile zone. So then, as I mentioned, shade selection should be done quickly within 5 seconds, because the eyes get fatigued very fast with the tooth color. And when if we are looking at a tooth for too long, we should look at something like a neutral background, like a blue color. So usually it is helpful that I look at the bib of the patient, because bib is blue in color. So for a few seconds, or close your eyes for a few seconds to to prevent the fatigue, and then again look at the shade. Usually the first shade that we select is the most accurate one if you are unable to decide. So these are tips for shade selection, and the shade tab should be wet. Usually what I do is I will wet the shade tab under the lip or in the floor of the mouth of the patient with the patient's saliva to make it wet slightly, and keep it next to the teeth and measure the shade tab. If you are unable to decide the shade, usually we can measure the shade for the gingival portion or the gingival third, and a shade for the incisal portion, and combine the two shades when giving to the lab. Mention both the shades. Okay, so these are the things about shade selection, and I hope it all made sense. Now coming to conclusion, it is clear now that the smile we create should be aesthetically appealing and functionally sound. So it is our duty to carefully diagnose, analyze, plan, and deliver the best to our patient to the best of our abilities. Okay, and we should also know when to refer the case to a specialist. Okay, the smile designing should be done by us to at a more conservative level as possible. We should not be try to be overzealous and do an aggressive type of smile designing requiring apically repositioned flap, or laser surgical procedures, bony augmentation, or orthognathic surgery, and such sort of things. So or excess or removal of the teeth, all these things. So we should be as conservative as possible, but at the same time our aim should be to give something which is more permanent or going to last for a long time. It should make sense to the patient, and it should be easy to maintain, and it should fulfill all the aesthetic needs of the patient and of the operator. Okay, so that is it, and thank you for a patient listening.